Humanity, rising to the challenge of a lifetime. But we're not done yet. Better has just begun. Let's make healthcare reach everyone. Let's push this world forward, because together we make life better.
Well, what a wonderful way to start today's session with a message from Philips. Together we make life better. Good morning all, and welcome to day 2 of the Qatar Telehealth Technology Summit 2022 on the experiences and lessons learned from the pandemic, and to discuss opportunities, challenges in telehealth. Organized by Trex Event in partnership with our platinum sponsor Philips and gold sponsor Advanced Care. This summit is a gateway to explore how healthcare will be delivered now and in the future. I am Roger, and we have Bridget, and we will be your hosts for today's sessions. We are indebted to the great state of Qatar and its leaders for their futuristic approach, love and care for all. Yesterday was a wonderful and power-packed day, and we learned about the insights, trends, solutions, predictions, experiences, and the way forward on telehealth and its impact. A few pointers to make the most of today's session. If for any reason you get logged out or stuck during the session, please log out and follow the same procedure to join or refresh your page. All our partners and speakers would love to answer any questions you may have. Kindly key in your questions in the Q&A tab that we have there. You can also set up a meeting or drop a message to them directly, and they will be available for questions in the lounge area. And don't forget to visit the booths to explore all that our partners can do for you. So without further ado, let's get started with day 2 of the Qatar Telehealth Technology Summit 2022 with a keynote presentation on the Qatar Diabetes Covid19 Program, a telemedicine story by our eminent guest of honor, Dr. Abdul Badi Abou-Samra, Chief Quality Officer and Deputy CMO, Hamad Medical Corporation. Dr. Abou-Samra received multiple recognitions for scientific contributions and led research continuously funded by the National Institute of Health between 1986 until 2014. He is known for his molecular and clinical research on G-protein coupled receptors, insulin action, and nutritionally generated genes. Dr. Abou-Samra published over 217 original papers in peer-reviewed journals and contributed to 5 USA patents. He served as a member of the NIH Endocrine Studies section and a member of the editorial board for several international journals. Dr. Abou-Samra joined HMC in 2013 as Chairman of Medicine. He was then promoted in 2020 to the position of Chief Quality Officer and Deputy for the Chief Medical Officer at Hamad Medical Corporation. He continues to be the director at Qatar Metabolic Institute and co-chair for the Qatar National Diabetes Committee. Let's welcome our guest of honor, Dr. Abou-Samra on stage, and over to you, Doctor.
Good morning, and thank you for inviting me to this wonderful session. So I'm going to tell you a story about Qatar Diabetes Covid-19 Program. I have no conflict of interest. I'll start with this slide from the Center for Disease Control and Prevention, which is continuously updated, and to state there that telehealth intervention actually are approved for to improve chronic disease. So specifically, they say there is for a systemic review, and which they put them on their website, that telehealth can showed evidence of effectiveness for the following disease, one of them diabetes, which I'm going to focus on, but these are there. So patient with recently diagnosed cardiovascular disease, there's effectiveness. For patient with high blood pressure, patient with coronary vascular disease, diabetes, HIV infection or asthma, and patients with cardiovascular disease, diabetes, interstitial disease, or obesity. These are 4 different review meta-analysis which show evidence for these in each of these peer-reviewed journal papers that were published and referenced by CDC. The outcome from this table, there's improvement in medication adherence, improvement in self-management, improvement in dietary outcomes such as diet quality and healthy intake, and benefit found for blood pressure control. So what I'm going to take you here is diabetes and COVID-19. When the COVID-19 epidemic started, there was clearly early literature to age. Diabetes is a major risk factor that increases morbidity and mortality from COVID-19 infection. Patients with diabetes who are treated to target have lower risk than those who are not. And then other hypertension, dyslipidemia, and vitamin D deficiency are also recognized as potentially modifiable risk factor, which commonly coexist in patients with diabetes. Qatar is one of the countries where with large prevalence of diabetes is about 17% of all adults are affected by diabetes, and prevalence is higher with age, meaning people who are above the age of 50 is not 17%, it's almost 25 to 30% and so on. Many patients with diabetes are not aware of their increased risk. So the National Diabetes Committee, which I co-chair, took a decision to establish the COVID-19 and diabetes program. And it is conceived as a population health management approach using telemedicine to identify patients with diabetes from electronic medical record who have high risk for COVID-19 complication, and use telemedicine and population health management objectives, empower patients to self-manage diabetes to target, inquire about other risk factors, hypertension, dyslipidemia, coronary artery disease, vitamin deficiency, obesity, and smoking, and provide management advice as appropriate. And therefore, a multidisciplinary task force, which is established, led by one of my colleagues, Dr. Professor Tahiri from Qatar Metabolic Institute, coordinated with primary healthcare leaders, one of the leaders of primary healthcare, Dr. Samuel Abdullah. And the task force reviewed electronic medical records for patients with type 2 diabetes having hemoglobin A1C data between 19 June 2018 and 19 June 2019. This was at, about the time of the epidemic coming in Qatar. A total of 91,702 patients was recorded in similar in the data range, and that excluded pediatrics. And we have about 25,000 hemoglobin A1C above 8, and 16,000 of them aged above 50, and 7,600 above 60. So the committee decided, the task force decided to go with the age cut of 50. So they decided select patients, dividing them between PHCC and HMC to manage them on the phone using telemedicine. The criteria, so those who have hemoglobin A1C between 8 to 9% and age above 50, they were managed by the PHCC team, that's about 10,500. And those who have above the A1C above 9%, and of course above age of 50, would be managed by Hamad Medical Corporation team, which is secondary and tertiary care doctors. All of them endocrinologists, diabetologists, PHCC, they are family physician and internist. And then the task force established specific question and to put it in a script to, so a person who will be calling the patient from the staff will go over that script, will ask what type of diabetes, and if it's type 1 or type 2, we'll record it in the sheet. I will ask about the smoking status and yes or no, and then that will help the healthcare provider to advise about smoking cessation. They will ask if the patient knows he has dyslipidemia or not, if he has prior history of coronary vascular disease, yes or no, if they has retinopathy, nephropathy, hypoglycemia, if they have obesity, if he has a history of bariatric surgery, he has up-to-date vaccination or not. If the person have home monitoring, doing home monitoring, if he does, then record the latest hemoglobin A1C, as well as the latest fasting and daily glucose the patient might have, and ask if the patient have vitamin deficiency, they are aware or not. And because that survey was prior to Ramadan last year of 2019, we asked if the patient planning to fast in Ramadan, and so we can consider glycemic control target and the medication. And if the patient already have follow-up plan or not, if not, then we book a follow-up plan. So the diabetes management program, the pathway, so the support staff will call the patient, complete the script, and log the response in progress note. And then nurses will review the info, decide if virtual clinic is needed, and virtual appointment created in diabetes clinic, and physician conducts virtual clinic and create record in CERNAP, and diabetes educator will follow up with the patient as per plan agreed with physician. So the patient will receive 3 calls: support staff, physician, and diabetes educator. And then that was done almost at 75% target was reached. And then we decided to do satisfaction survey and so we decided to look for establish a target number of 88. And so what's the satisfaction survey? Essentially question objective to understand if the patient score it for clarity. So the patient will be say, I received clear information during the first call about COVID-19 and diabetes program. So meaning learn the program, learn his risk, etc. And would say if the physician listened to me carefully when she contacted me, if the physician explained to me and I understood, if the patient understands better how to control my blood sugar than before the call, if the patient feel empowered, if the patient now has this anxiety, and if the educator call also was very useful for his support, and to assess medication and supply, access medication and supply. During COVID-19, we established a way to deliver medication and supply to the patient home, and patient empowerment if he feel now he can manage his own diabetes and he know how to handle it. And we also score for our all patient satisfaction. This is a survey respondent. So we have 69 accepted the survey, and this is the outcome. Essentially, almost above 90% of them, they were either agree or strongly agree with the statement, meaning satisfied or very satisfied. And so this was an initiative done by National Diabetes Committee and supported by HMC and PHCC. The initiative was published in Letter to Lancet in June 2020. And I clearly send special thanks to all physician, nurse, and educator, administrator, allied health professional who actually worked on this on volunteer basis during the pandemic. Now we'll come back to the advantage of telehealth in Qatar Diabetes Program, so I can summarize here. Telehealth saves patients, of course, from coming to clinic, which become a potential source of infection. So we are managing them at home. Population health management now is possible with telehealth because the objective is to manage, define the group of people based on criteria pre-established, and here we've established the criteria of the age and hemoglobin A1C. And the care model here is telehealth. And also the telehealth will allow us individual health management, so not just population health. We actually been following patients who have prior appointment by telehealth. Other benefit, of course, cost, access, and saving time for patients, that's also very useful. In fact, with the telehealth, we have seen less no-show than when they come in person to the clinic. Disadvantage, of course, everything has disadvantage. We could not assure patient confidentiality. Most of the time in the room, there's somebody else when the patient call, and sometimes the patient say, I want my father or mother or helper to call, and we don't know who's in the other line. We don't have video monitoring. We are using telephone-based. Important physical finding may be missed, and also vital sign may not be accurate. The patient may estimate his weight, height, temperature, etc., so doesn't want to appear like he doesn't know, and that can raise potential harm. In fact, we do have potential harm, not from the diabetes clinic, from another clinic which one run virtually, and that the patient has chronic back pain history, and he would call, give him pain medication, so back pain never examined. But when the person came and examined, there was an abscess. There was an abscess in his back. It was a TB abscess that was growing almost like 10 centimeters. It's luckily was TB, meaning it was something else would be dying. And so it needed surgery. But what I'm saying is that's a major disadvantage. Time spent by providers sometimes is much longer than in the face-to-face clinic, because it takes time to identify the patient, chat with him. So it may take longer than an actual face-to-face clinic when the patient is prepared by the nursing staff and there is a pre-assessment, etc. The patient-provider relationship is weakened here because you don't have that face-to-face touch. And also we are missing the benefit of multidisciplinary team in which the physician, dietitian, and health educator discuss together about the management plan for the patient, and that cannot happen in that, in this environment. So these are multiple disadvantages and the disadvantage. So I thank you for listening. I hope you benefited from what I said. If there's a question, I can take a few questions.
In case we do have any questions, Doctor, we go ahead and send them to you, and then you can respond. As of right now, we don't see any questions being asked. All right.
Okay.
Thank you, Dr. Abou-Samra, for sharing your knowledge and insights with us today. Hope you have a great day ahead and continue to enjoy the day. All right.
Thank you, Dr. Abou-Samra. Thank you so much for your time.
Okay, thank you.